absolute risk. So far you have been familiar with risk.
Yes.
Yes?
Yes.
So
Very true.
we are actually reviewing absolute risk in this session as well to introduce and compare relative risk and odds ratio as measures of association. So we will be talking about the measures of association this session, to calculate and interpret a relative risk in a cohort study, and to calculate and interpret an odds ratio in a cohort study and a case control study, and to describe when the odds ratio is a good estimate of relative risk or risk ratio, and to calculate and interpret odds ratio in a matched pair case control study, to calculate and interpret the attributable risk. So another concept which I hope that we can talk in this session is attributable risk for the exposed group, and interpret the population attributable risk or population attributable fraction. And lastly, we will be talking about how attributable risk is used to estimate the potential for prevention. So, let's look at some common and main designs of epidemiological study. We will be talking about these designs in more details tomorrow, but let's look at the basic concepts, because we need the basic concepts of these designs. This is a clinical trial study. In clinical trial study, we have the study population, let's say a population of diabetic patients. So we have a population of diabetic patients, for example. We select, for example, 200 of these diabetic patients to actually investigate a new treatment, to see if the new treatment is effective against diabetes, for example, for controlling the blood sugar or not. Okay? So we randomly assign these 200 cases of diabetes into two groups. The first group received new treatment, and the second group received current treatment or no treatment or placebo. And we will follow both groups, those who receive new treatment and the group who receive current treatment, to see the rate or risk of improvement in each group. So we have a prospective design in the future, we have follow-up, and we can compare between two groups the rate or risk of improvement between new treatment and the current treatment or no treatment. If the risk of improvement is higher in new treatment group, it means that the new treatment is effective. Okay?
Yes.
So we have randomly assigned people to two groups by chance. Okay? In cohort study, there is no randomly assigned exposure, because the exposure in cohort, the exposure of investigation in cohort studies are actually potentially harmful. So we cannot, for example, random people to the group of, for example, smoking and not smoking. We cannot recommend people to smoke. Please come here. So we just follow those who are exposed in a specific population and those who are not exposed. Which means that those, for example, who smoke and those who actually don't smoke. Okay? We cannot recommend a group to smoke and another group to don't smoke. Okay? So we follow both groups to see if the disease occurs in exposed group more than unexposed group.
Isn't the exposed group about the disease? Like, does the disease have affected the group?
We are going to investigate the association between a specific exposure and a disease, exposure and outcome. We want to see if smoking is a cause of
Asthma.
asthma, is a cause of lung cancer. So we compare a group who smoke and a group who don't smoke and see if the rate of disease is
Got it.
greater in those who smoke or not.
So it's a
So
sort
this
of
is a
comparison.
cohort study.
Got it, sir. Got it.
Okay? Another design is case control study. Sometimes we have to wait for a long time to see if smokes affect disease or not. And sometimes 10 years, 20 years, we have to follow many actually people to see if disease occurs or not. So in an easier design, we can actually go to a hospital and select, for example, 100 cases of lung cancer and compare with a group of those who do not have lung cancer in terms of their past exposure to smoking. So we ask from those who have lung cancer and a control group, which are those who do not have lung cancer, about the story of actually smoking. We ask them if they have exposure to smoking or not. So we can compare then the proportion of those who smoke in case group with the proportion of exposure in control group. So this is the case control study. Okay? So we have reviewed clinical trial studies, cohort studies, and case control studies. As I mentioned, we'll go through details of these kinds of studies tomorrow, inshallah. But now, we want to
Basically,
discuss concept of risk and how we can calculate risk, because our primary interest is to investigate if there is any association between the exposure and the outcome. We want to see if physical activity or if insufficient physical activity can cause depression. So there is an exposure, which is insufficient physical activity, and there is an outcome, which is depression. And we design a study to see if there is any association between these two variables, between exposure and outcome or not. So let's review the concept of risk. The fundamental difference between a randomized trial and cohort study, as I mentioned, is that in cohort study, subjects are not randomly assigned to be exposed or remain unexposed. I discussed that because exposure is a potentially harmful exposure, so we cannot actually assign people to these harmful exposures. But in clinical trial or randomized controlled trial, the exposure is treatment, so it has a potential benefit. So we can assign people to those who receive this potentially beneficial treatment and compare them with those who do not receive this potentially beneficial treatment. Okay? So this is a difference between cohort study and randomized controlled trial or clinical trial.
Sir, can you repeat again what was cohort and randomized study and non-randomized?
You know, randomized clinical trial are designed to see if a new treatment is effective or not. Okay? So we divide our patients, our study population, into two groups. One group receive treatment or new treatment, and another group do not receive our treatment. So we can compare these two groups if the improvements occur actually in those who receive treatment or not. If the rate of improvement is greater in those who receive treatment, we say that that new treatment is effective against that disease. Okay? But in cohort study, we just see in this class, who smokes, who doesn't smoke. We do not recommend, please go and smoke, please do not smoke. We just observe, we just see who smokes and who do not smoke, and follow you for the following 10 years, and to see if you develop asthma or not, and compare these two groups, those who smoke and those who do not smoke, and compare the risk of asthma between these two groups. This is a cohort study. This is an observational study, not interventional study. Clinical trial is an interventional study, while cohort study is just an observational study. Okay? In case control study, again, our interest is to see if there is any association between exposure and outcome, between smoking and asthma. Again, our interest is to investigate this question. Okay? But the design is different. Instead of dividing study population into those who smoke and those who do not smoke, and wait for 10 years to develop asthma, we compared two cases, two groups, those who have already developed asthma, and those who do not have developed asthma. So there are two groups, a group of cases which have already disease, and a group of controls who do not have the disease. Okay? And ask about the history of exposure in the past. We ask them if they have already, for example, in the previous 10, 20 years, have been smoking or not. And compare the proportion of smoking in the group of asthma patients and the control group. And if the proportion of those who smoke in asthma cases are greater than control group, we can say that there is an association between smoking and asthma. So this is the design of case control. But still, our interest is investigating the association between smoking and asthma, but in a different way. Regardless of which design is used, the objective is to determine whether there is an excess risk or perhaps a reduced risk of a certain disease in association with a specified exposure or characteristic. In all three designs that I explained for you, our interest is to see if there is excess risk for those who smoke compared with those who do not smoke or not. If the risk is more in those who smoke, we can say that there is an association between exposure and outcome, between smoking and asthma. Okay? So, in this session, we will be reviewing measures of association between exposure of interest and outcome of interest. And this is actually the purpose of that branch of epidemiology that I already mentioned, analytical epidemiology, not descriptive epidemiology. Descriptive epidemiology concerned with actually the questions of when, where, and who. But analytical epidemiology concerned with the questions of why and how. So if there is an association between exposure and outcome, we can say that specific exposure can be cause of that outcome, that disease. So we can do some intervention to reduce the risk by reducing exposure, by cutting the exposure, or by recommending not to actually not to expose with that specific risk factor. So these are measures of association: risk ratio or relative risk, rate ratio or relative rate, odds ratio or relative odds, or cross product ratio. You became familiar with the concept of ratio today, yes?
Yes.
So all three measures of association are ratios, which means that numerator and denominator are not the same, or numerator is not part of denominator, okay? So we will see how these actually measures of association are ratios. Before going ahead, let's review our terminology. Do you know what incidence is? What is incidence? Occurrence of disease. This is a general term. The formula is the number of new cases in the numerator divided by the number of people who are at risk in the denominator, number of those who are at risk actually in that specific period. Yes, this is incidence. But incidence itself is a general term. There is another specific term which is cumulative incidence or risk. In risk, the numerator is the same, the number of new cases in a specific time period. Okay? But the denominator is different. The denominator is the number of people who are at risk at the beginning of that specific period. So, sorry? Yes. So, if for example we want to calculate the risk or cumulative incidence in a year, those who are at risk at the beginning of the year, the first day of the year, would be placed in the denominator. And those who occur the disease during the specific year would be as the numerator. So the numerator, or X, is the number of new cases in that specific period, and Y, or denominator, is the number of people who are at risk at the beginning of that specific period. What is incidence rate? An incidence rate, again, numerator is the same, but the denominator is the average of the population at that specific period. Average means number of people at the beginning plus number of people at the end divided by 2. Okay? So this is the average of population. And incidence density, what is incidence density? For the incidence density, also the numerator is the same, the number of new cases in a specific period, but in the denominator, we have the number of person times at risk. The number of person time at risk. So, then for all of these actually measures, the numerator is the same, but denominator are different. We have another concept, which is odds. Do you know what the odds is? You don't know. Actually, odds is a term used in the gaming industry, in gambling. When you are betting, for example, on a horse, in a horse riding race, you may say that I bet on this horse 3/1, which means that the probability or the risk of winning for this horse is 3 times against the probability of not winning or probability of losing. So odds is probability of occurring something divided by the probability of not occurring something. So if the probability of actually winning the horse is 75%, so you imagine that you know or you guess that probability of winning this horse in this race, in this horse riding race is 75%. The probability or the risk is 75%. Probability of not winning is 25%. So 75% to 25% is 3 to 1. So you say that I bet on this horse 3/1, which means that probability is 75%, but in a different way. That is odds. The odds of winning this horse is 3/1. The probability of winning over the probability of losing or probability of not winning. This is the case for exposure. This is the case for outcome, for the disease. The probability of having exposed to probability of not having exposed is odds of exposure. The probability of getting disease to the probability of not getting sick is odds of disease. So odds is another concept that is actually fundamental for epidemiology and for medical actually literature. So you have to know the concept. You have to know the concept of odds. So with this review, let's proceed to actually absolute risk. What is absolute risk? Absolute risk, the incidence of disease in a population. Simply, from now on, we use all those kinds of incidence rate, risk, incidence density as risk. We treat all of these concepts the same. Okay? So if you want a concept of risk, we can generalize this concept to others. Okay? So absolute risk is the risk, is the incidence. An absolute risk can indicate the magnitude of the risk in a group of people with certain exposure. What is the risk of getting disease for those who smoke? What is the risk? You know, 50% of those who smoke die from different diseases. So the risk of dying from smoking for those who smoke is 50%. Did you know? Did you know that? That 50% of those who smoke will die from smoking during their lifetime. Will die. All of actually those who don't smoke will die.
From other course.
Okay. So absolute risk, the formula for absolute risk is number of new cases in a time period divided by number of people at risk in that time period. This is the formula, the general formula for absolute risk. Let's look at an example. Come on, please. Let's look at this example. This is data collected after a foodborne outbreak, a food poisoning outbreak. These are food items that have been served in that party. And these are risks for getting sick for those who ate each food item. Which means the risk of getting sick for those people who actually ate egg salad in the party is 83%. 83% of those who ate egg salad got sick. Okay? So, please write your names for this session. Thank you. What does it mean? What does it mean? Come on.
High risk.
Absolute risk for
egg
those
salad.
who ate egg salad is 83%.
High risk.
Comparatively higher.
It is 76% for macaroni, 71% for cottage cheese. I don't know what this is. Do you know what is cottage cheese?
Paneer.
I know cheese is paneer. What is cottage?
Which is made at home. Cottage means home, little house.
Mahalli. Paneer
House.
mahalli.
Homemade. Generally.
Thank you. The absolute risk for tuna salad is 78, and for ice cream is 78, and for other food items is 72. So, which food item is responsible for the disease?
Egg salad.
Excellent.
Egg salad. Why?
Most
Salad is high risk.
It is good, but 76% of those who ate macaroni
like rasa.
got sick. You like macaroni?
Yes.
Me too.
If so, sit make.
And 78% of those who ate tuna salad actually got sick as well. So, which one is responsible?
And he is a cook.
It seems that we need further information
Yes, sir. Exactly.
to be able to actually calculate excess risk. We need to know what the absolute risks are in those who did not eat that food item. Okay? And your guess was right. Excellent. Because the absolute risk for those who did not eat egg salad was 30%. And for macaroni is 67, for cheese is 69, for tuna salad is 50, for ice cream is 64, and for other items is 52. Again, the same question. Which food item is responsible? Which food item? Ladies? Excellent. Yes, why? Because has the most percentage?
You see, 83 of them get sick by eating.
Okay.
Oh no, sorry, the answer is cottage.
Why again? You have to mention your answer.
Sir, definitely it is the egg salad, because if you see the relative ratio of the two, egg salad has the most relative ratio, 83 upon 30, which is the most.
Because the percentage difference of percentage is highest.
Is higher, is greater for egg salad. Because risk difference, it means absolute risk in those who ate that food item minus the absolute risk among those who did not eat that food item is greater for egg salad. So, to calculate excess risk, so if you want to know if there is any association between these food items
Difference of the two.
and the disease of interest, we have to calculate the excess risk. The excess risk that is due to exposure to these food items. Okay? Because those
So you
who
are
did not eat egg salad had actually absolute risk of 30%. And the risk difference between those who ate and those who did not eat is, what is the absolute risk?
53.
53.
53.
So we can calculate risk difference as the measure of excess risk.
Got it.
53 For egg salad, 9, which is nothing,
Raza is
which is near 0.
yes, sir.
For macaroni, for cheese it is 2. For tuna it is 28. For ice cream is 24. For other is 22. So the greater risk difference is for egg salad. Do you know how we can calculate the excess risk? Another actually measure of association is relative risk.
Sir,
What is relative risk?
the ratio of the two.
The ratio of these two risks, these two absolute risks. Absolute risk in those who ate and absolute risk in those who did not eat. So we can divide these two absolute risk to calculate the relative risk or risk ratio.
So I was talking about this. Can't we say on the basis of relative risk, which is more dangerous?
Yes, actually, please wait. I will explain for you what's the difference between risk difference and relative risk.
Okay, sir.
And we're talking about it in more details. So again, the risk ratio for egg salad is greater than other food items. What does it mean? What does 2.77 mean?
So relatively, the risk of eating egg salad is much more than others. So like relatively.
What's the difference between risk difference and relative risk? So it means that absolute risk in those who ate is 2.77 times of those who did not eat. It's simple. So it's the difference, it's the ratio. Because it means that those who ate that food item has 2.77 times risk of getting sick. Okay? That is the risk ratio. So the formula is like this. The ratio is disease risk in exposed group divided by disease risk in unexposed group. And this is unitless. It means that there is no unit for risk ratio. It's just actually dividing two risks. Okay? And what is the difference? What is the risk difference? Is disease risk in exposed minus disease risk in unexposed. And the unit is percent, because it's again the same as risk. The excess risk that is due to, or that is attributable to the exposure of interest. So these are formula for risk difference and for risk ratio or relative risk. But the question, does the method that we choose to calculate excess risk make any difference? Which method is better? Risk difference or risk ratio?
Risk ratio, yes.
Why?
Because it tells you exact, quantity, how much risk the person is while if he is eating a certain food and how much he is safe. Simultaneously, it tells you about the other foods as well.
Okay, what do you think? Which one is better?
I think the difference
Why?
in ratio you will have like a decimal value.
Actually, the answer is it depends. It depends on actually the application of the calculation of excess risk. Let's go through that. Please see this table. There are two populations, population A and population B. In population A, the risk of getting sick is in exposed group is 40%, and the risk of actually getting sick in unexposed group is 10%. And population B, these risks are 90% for exposed group and 60% for unexposed group. What is the risk difference?
Same, 30. 30,
30,
same.
the same. Yes, so the risk difference is the same. What about risk ratio? Relative risk.
It will be different.
Different.
0.24.
4 for this one, and 1.5
So
for population B. So, which one is better?
Relative risk.
Relative risk. Why? Again?
Because in risk different, both are same, then we cannot.
we are unable to
Yeah.
Yes,
categorize
you
it.
cannot
Distinguish
discriminate between
which one is
actually
more
risk
relative.
difference and relative risk in population. But the answer is again, it depends. And we can see that each method has its own application and its own interpretation. Okay? So, how can we interpret relative risk? If relative risk is equal to 1, it means that there is no
No
difference
exposure.
between risk in exposed group and
And
unexposed group,
No different.
which means there is no association between exposure and outcome. So, neutral relative risk is 1. If it is higher than 1, it means that the risk
Greater.
is exposed group is greater than unexposed group. So it means that there is a positive association, possibly causal association, between the exposure or risk factor and the outcome or the disease. And if a relative risk is lower than 1, it means that risk in exposed group is lower than the risk in unexposed group. For example, in physical activity, in association of physical activity and cardiovascular disease, the risk would be lower than 1, which means physical activity is a protective factor for cardiovascular disease. So relative risk higher than 1 means that exposure of interest is a risk factor. And relative risk lower than 1 means that the exposure of interest is a protective factor, or there is a negative association between the exposure and the disease. So this is how we interpret relative risk in epidemiological studies. So this is the formula of risk calculation and relative risk calculation in a cohort study. If we follow, for example, a number of exposed people and a number of not exposed people, for example, 1,000 exposed and 1,000 unexposed people, and this is the number of people who got sick during the time period that we are following our study population, for exposed group and for not exposed group. So this is epidemiological table, or 2 by 2 table. 2 by 2 table or epidemiological table. So we have in column, actually in rows we have exposure status, and in column we have disease status. Okay? So the number of people who were exposed is A plus B. The number of people who are not exposed is C plus B. From this, A out of A plus B has been actually developed disease, and C out of C plus D have been developed disease in unexposed group. So we can calculate incidence in exposed group A over A plus B, and in non-exposed group is C over C plus D. And the relative risk would be incidence in incidence in exposed divided by incidence in unexposed, which means A over A plus B divided by C over C plus D. This is the formula for relative risk. Let's look at this table. So imagine that we have 3,000 people who smoke and 5,000 people who do not smoke. So 3,000 smokers and 5,000 non-smokers. Out of these 3,000, 84% got coronary heart disease, and out of these 5,000, 87 develops coronary heart disease. What is the incidence in smoker and non-smoker, and what is the relative risk? A over A plus B in exposed, and C over C plus D non-exposed.
84 upon 8.
Yes. Incidence among the exposed is 84 over 3,000.
Yes, sir. And
Is 28 per thousand. Okay, per thousand per year. And incidence among unexposed is 87 divided by 5,000, which is 17.4. Okay? So we have these two incidences. What is the incidence ratio?
The
28
exposed
divided by
non-exposed.
74. So the relative risk or risk ratio is incidence in exposed divided by incidence in unexposed, which is 1.6.
1.6 times.
What does it mean? What does 1.6
times
mean?
more susceptible. 1.6
exposed
times
are more
exposed.
susceptible than
First,
unexposed.
First, smoking is a risk factor of coronary heart disease because our relative risk is greater than 1. But how much?
1.6
1.6 times.
The who is
Those
smoking
who smoke
has more
have
chance
the
of having-
risk of, have 1.6 times risk
Greater.
of developing coronary heart disease compared to those who do not smoke. Okay? So this is the concept of relative risk. It was a very simple, actually, example for which we had just 2 levels of exposure and 2 levels of outcome. But there may be some more complex cases like these. You know, these are levels of serum cholesterol lower than 190, 190 to 219, 220 to 250, and higher than 250. These are different levels of exposure. Hypercholesterolemia is defined as a cholesterol level higher than 190, but there are different levels of cholesterol. And also, these are incidence rates or risks. Okay? In different groups, there are actually incidence rates for men and women separately, and for those who have in the age range of 30 to 50 years old and 50 to 62 years old. So there are many risks in this table. And you have to calculate relative risk. How do you do that? You have to select one group as the baseline, okay? And divide other risks, other absolute risks, other incidences by that actually baseline. So in this case, it is arbitrary. Which one is selected is arbitrary. It's actually up to you. So in this case, we choose actually men who have 30 to 50 years old and have the cholesterol level of lower than 190 as baseline, and divide other incidences by this incidence. So if we want to know other risks, for example, in this group, we can divide 105 by 38, and the relative risk is 2.8. What does it mean? It means that men's who have age of 50 to 62,
Yes.
incidence of the disease for men of 50 to 62, 2 times of men who are in the range of 30 to 50 years old. In those who have serum cholesterol of lower than 190. So the interpretation is also very important. For all cases, you can compare that specific cell to this baseline one. If you want to compare this one, for example, women who have 50 to 62 years old, compared to, again, women who have 30 to 49 years old, you should divide this one by this one. Okay? And you can see that, for example, there are 15 times actually greater risk for those who have 50 to 62 compared to younger ages women. Okay? So sometimes the case is more complicated than what we explained before, but the concept is the same. Concept is exactly the same. All of these are just a ratio of one risk by another risk. Okay? So the concept is the same. So let's move to odds ratio, or relative odds. You know, we talked about different designs, and we discussed that we can calculate the risk in clinical trial studies and cohort studies, but the risk cannot be calculated in case control studies. Because in clinical trials and cohort studies, we move from exposure to outcome. We have those who are exposed and those who are not exposed, and follow them to see the development of the disease. So we can directly calculate the risk in cohort and clinical trial studies. But unfortunately, in case control studies, we cannot directly calculate the risk. So there is another measure of association, which is odds ratio. Odds ratio can be calculated in both cohort studies and case control studies. Let's say how. If you remember case control studies, we had a group of cases, for example, 100 cases of asthma, and a group of controls, for example, 100 people who do not have asthma. And we will see if they have past exposure to smoking or not. So the proportion of exposure to smoking in cases and controls can be compared. If the proportion of exposure in these 100 cases who have asthma is greater compared to those who do not have asthma, we can say that smoking is associated with asthma, or smoking is a risk factor for asthma. So, how we can calculate actually odds ratio in case control studies? In case control studies, we do not have people who are exposed and people who are not exposed. We have a group of cases and a group of controls. And the group of cases, we should see how many of them are smokers. And in the group of controls, we should see how many of them do not smoke, do smoke. So the proportion of the smoking in those who are cases, for example, those who have asthma, is the number of A plus C is old cases, for example, 100 cases, and A is the number of asthma cases who smoke, who have a history of smoking. Okay? And those who have not asthma, again, we can calculate the proportion of those who smoke. So the proportion of exposure in cases and controls are A over A plus C, and in control is B over B plus D. But how can we calculate odds? Do you remember what was odds?
3 by 1.
Like the
Probability of something
Which is happening,
to probability of
which is not happening.
Like probability of winning life divided by
probability of occurring disease by the probability of not occurring disease. Probability of being exposed, probability of not being exposed. So we can calculate odds here in case control studies. So what is the probability of exposure in cases? Probability of exposure in cases. This is A over A plus C. What is the probability of unexposure? It is C
C
over A plus C. So what is the odds? Probability of exposure to probability of not exposure, which is A over A plus C divided by C over A plus C, which is A over C, because A plus C is common in both. So this is A plus C, which is odds of actually exposure in cases. What is odds of exposure in controls? B over B plus D divided by D plus D plus B plus D. And B plus D is common in both. So the odds is B over D. So this is not in case control studies. This is wrong. You know, this is for cohort study. So if we want to calculate odds ratio, we should divide these two odds of exposure in cases divided by odds of exposure in controls. So it means that A over C divided by B over D, which is A multiplied by D divided by B multiplied by C. A multiplied by D divided by C multiplied. This is the formula for odds ratio in case control studies. A multiplied by D divided by B multiplied by C. So odds ratio can be calculated in both case control studies and cohort studies. But in cohort studies, risk ratio can be directly calculated because risk can be directly calculated. But in case control studies, we cannot calculate risk. So we can only calculate odds ratio because odds can be calculated in case control studies as well. So let's look at these two cases. This is cohort study. This is exposed group and not exposed group. And these are those who develop disease among exposed group and unexposed group. So what is the odds of developing disease in exposed group? A over B. What is the odds of developing disease in not exposed group? C over D. So odds ratio is the actually dividing odds in exposed group, odds of disease in exposed group divided by odds of disease in unexposed group. Sorry. So A over B divided by C over D, and it's AD divided by BC. Okay? What about case control studies? In case control studies, we have not exposed and we do not have exposed and not exposed group. We have cases and controls. What are the odds of exposure in cases? A over C. What is odds of exposure in controls? B over D. And again, the formula is A multiplied by D divided by D multiplied by C. So the formula is the same for both case control and cohort studies. The way we calculate odds are different, but the formula is the same. If you want to calculate odds ratio, it's enough to find a cell. A cell is where actually cases and exposure, disease and exposure is. So A is where people are exposed and people are developed disease. People are cases, which means that they have disease, and people are exposed. So if you find A, you can multiply it by D and divide it by multiplication of D and C. And you can simply calculate odds ratio. Okay?
Yes.
Why do we calculate odds ratio? Because in case control studies, we cannot calculate risk. So we cannot calculate risk ratio. So we have to calculate odds ratio. So this is again in cohort studies, exposed and not exposed group, and disease and not disease. So odds ratio is A multiplied by D divided by D multiplied by
C.
This is calculation of odds ratio in cohort studies. What about in case control studies? In case control studies, we have cases and controls. We have exposure in cases and exposure in controls. Again, odds ratio is A multiplied by D divided by D multiplied by
Previous slide. Can you please?
previous slide.
Yes. In the order, it shouldn't be like A over B.
Sorry?
Like the odds column.
A over B. You know, in cohort study, you want to know what is the odds of disease in exposed group. A over B, okay, divided by C over D. But in case control studies, A over C divided by B over D. But the result is the same. Yeah. That's why we say odds ratio as cross product ratio. This is cross product ratio because it's calculated the same way in case control studies and cohort
We get the
studies.
same.
What is the interpretation of the odds ratio? The interpretation is the same as risk ratio, which means if it is greater than 1, the exposure is
More risk.
the exposure is risk factor. And if it is lower than 1, it is protective factor. And if it is equal to 1, it means that there is no
Exposed
risk.
equal.
Okay? So please remember that even in case control studies, we are investigating the association between an exposure and an outcome and a disease. So the interpretation are the same. You know, the way we are calculating actually the measure of association is different, but the interpretation is the same. And we then say that smoking has association with asthma in both case control studies and cohort studies. Regardless of we calculate risk ratio or odds ratio. When is the odds ratio a good estimate of relative risk? Because we prefer to calculate risk ratio through a cohort study, but we cannot wait until 20 years to actually conduct a cohort study. So we go and design case control study and calculate odds ratio instead of risk ratio. Actually, odds ratio is an estimate of risk ratio. And when is this estimate is valid? When is the odds ratio a good estimate of a relative risk? You know, in case control study, only odds ratio can be calculated as a measure of association. We talked about it. So there are three conditions for the odds ratio to be a good estimate of risk ratio. The first one is when the cases studied are representative with regard of history of exposure to all people with the disease in the population. So cases should be a good representative for all cases. Cases who are included in our study should be a good representative for all cases. And controls also should be a good representative for those who do not have the disease. And the most important condition is that the disease of interest is rare. If it is not rare, odds ratio is not a good estimate of risk ratio. Let's look at this example. This is epidemiological study. Let's say 10,000 exposed group are compared with 10,000 unexposed group, and from which 200 develop disease among exposed and 100 among not exposed. Okay? So, can you say what is the risk of disease in exposed group? What is the risk in exposed group? What is the risk in exposed group? Can you help me? What is the risk? Yeah. What is the risk in exposed group? Can you calculate the risk? Risk of disease in exposed group. We said that risk is dividing
200 upon 9,800.
200 to 10,000. 2%. 2%. 200
2%.
among, okay?
2%.
So, and what about not exposed group?
1%.
So the disease is relatively
That's
rare.
8%.
Okay? So, would you please calculate risk ratio? Robert, please. 2.
2,
How did you calculate?
2 upon 1.
2%
Upon,
over
upon
1%. Okay, so risk ratio is 2. What about odds ratio?
2%.
How did you calculate odds ratio? 200 multiplied by 9,900 divided by 100 multiplied by 9,800. So odds ratio is 2, and risk ratio is 2, and odds ratio is 2.0.
Which is 2 hours.
So odds ratio in this case is a good estimate of risk ratio. Okay? Why?
It gives you
Because the
minor
disease is
accurate.
rare. Let's look at this scenario. What is the risk of disease for exposed group? What is the risk for exposed group? 50%. What is the risk for not exposed group? 25%. So disease is not rare, it's common. Okay, the disease is common. So what is the relative risk? Again, 2 for relative risk. What about odds ratio?
50 multiplied by 75 divided by 50 into 25.
Odds ratio is 50 multiplied by 75 divided by 50 multiplied by 25, which is 3. Is odds ratio is a good estimate of risk ratio? No. Why? Because the third condition that we mentioned is not met. We do not have a rare disease here. So if the disease is not rare, we cannot do a case control study to estimate the relative risk by an odds ratio. So it is a very important assumption that for odds ratio to be a good estimation of risk ratio, the disease of interest should be relatively rare. So remember, to summarize, the relative odds or odds ratio is a useful measure of association in both case control and cohort studies. In a cohort study, the relative risk can be calculated directly, so we don't need to calculate odds ratio. However, odds ratio has its own personality in epidemiological studies and its own characteristics, so it is calculated in cohort study in advanced epidemiology or in biostatistics. But we don't need, in many cases, to calculate it. But in a case control study, the relative risk cannot be calculated directly, so that the relative odds or odds ratio is used as an estimate of the relative risk when the risk of the disease is low, which means that the disease is rare. Okay?
Yes.
So